Hi everyone, and welcome to our module on hypertension. Let's start by talking about the diagnosis of hypertension. The first thing you should know is that to make a diagnosis of hypertension, you need more than one measurement. Many of us over the course of the day will have a transiently elevated blood pressure at one point of time or another. So before you diagnose and begin treatment in a patient with hypertension, you want to have two separate measurements to confirm that the patient truly has chronically elevated blood pressure. The most recent guidelines define a normal blood pressure as a systolic less than 120 and a diastolic less than 80. If the systolic is 120 to 129 and the diastolic is less than 80, that's called pre-hypertension. Stage 1 hypertension involves a systolic of 130 to 139 or a diastolic of 80 to 89. Stage 2 hypertension is a systolic greater than 140 or a diastolic over 90. And then finally, hypertensive crisis, which we'll talk about later in this video, is a syndrome of severely elevated blood pressure, and the generally accepted definition for hypertensive crisis is a systolic over 180 or a diastolic over 120. The vast majority of patients you will see with hypertension have what's known as primary or essential hypertension. The cause of this is not clear. These patients simply have high blood pressure in absence of any other pathologic process that could cause their blood pressure to be elevated. A much smaller percentage of the patients you'll see with high blood pressure have blood pressure that is elevated secondary to some other pathology. Most of these patients have chronic kidney disease. Patients who are on dialysis or otherwise have chronic kidney disease almost always have hypertension secondary to their kidney pathology. Other more rare causes include hyperaldosteronism, renal artery stenosis, pheochromocytoma, and there are others. And then finally, a very common occurrence in the clinic is what's known as white coat hypertension. These are patients who develop elevated blood pressure only when they're evaluated in clinic. For some patients, it provokes anxiety to come to the clinic and their blood pressure will rise, but if you check their blood pressure at home, it will be normal. Some of the important risk factors for primary hypertension are shown on this slide. First of all, family history is a risk factor, and this is one of the important non-modifiable risk factors. These other risk factors shown here are considered modifiable. First of all, high salt intake is associated with hypertension. If you consume lots of sodium, like what is found in hamburgers and French fries, like shown here, your body will hold onto water to balance the sodium, and that will raise the intravascular volume, and that can lead to hypertension. Chronic alcohol use is also associated with hypertension. A classic board question is to describe a patient with refractory hypertension and ask you what to do next. And if the question tells you that the patient consumes alcohol regularly, often if the patient is able to stop drinking, their blood pressure will improve. And then beyond these things, obesity and physical activity are also well-described risk factors for primary hypertension. So the reason hypertension is bad is because it's associated with lots of vascular diseases. In particular, it's associated with stroke and heart disease, including myocardial infarction and heart failure. It can also damage the kidneys, and hypertension is associated with renal failure. And then finally, the high blood pressure can damage the aorta, so patients with hypertension often develop aortic aneurysms and can develop aortic dissection. In patients with newly diagnosed hypertension, one of the most important first steps is to screen them for complications and comorbid conditions. Many times when hypertension is diagnosed, other things are already going on pathologically, but the patient is unaware. So for example, patients with new onset hypertension should have measurement of a hemoglobin A1C or fasting glucose to screen for diabetes. They should have a lipid panel to screen for hyperlipidemia. They should have an EKG to look for Q waves that indicate a prior myocardial infarction or left ventricular hypertrophy. They should have a serum creatinine to screen for kidney disease, and they should have a urinalysis to look for protein in the urine. This is super high yield for board exams. They will often describe a patient with new onset hypertension and ask you what to do next, and the answer is to screen them for complications and comorbid conditions. Let's talk about the treatment of hypertension. For most patients with new onset hypertension, the first line treatment is lifestyle modification. In a board question, if it describes a patient with new hypertension, do not choose a drug. The answer is almost certainly lifestyle modification. The most effective intervention that patients can do to lower their blood pressure is lose weight. I've seen patients lose just 5 pounds of weight and have their blood pressure drop by 10 or 15 points. The second most effective intervention is the DASH diet, and you should know this diet because it's been shown in clinical trials to be effective in reducing blood pressure. DASH stands for the Dietary Approaches to Stop Hypertension, and it's a diet that has lots of fruits and vegetables, whole grains, poultry and fish, and it's relatively low in sugar and red meats. Other lifestyle modifications include recommending exercise, restricting sodium like we talked about before, and also limiting alcohol intake, also like we talked about before. After a trial of lifestyle modification, if the patient remains hypertensive, that's when you can initiate drug therapy. And there are three recommended initial choices in terms of drug treatment of hypertension. These are the thiazide diuretics, ACE inhibitors or angiotensin receptor blockers, and dihydropyridine calcium channel blockers. And the dihydropyridine drugs are drugs like amlodipine. The guidelines recommend choosing a particular drug or drug class when patients have a compelling indication, and I've listed these on this slide. So in patients who have had a prior myocardial infarction, they should be treated for hypertension with a beta blocker, because the beta blocker is useful in treating the myocardial infarction, and it's also useful for treating hypertension. Patients who have diabetes should be treated with an ACE inhibitor or ARB, because these drugs have been shown to reduce the risk of developing diabetic kidney disease. Patients with osteoporosis should be treated with a thiazide diuretic, because thiazide diuretics slightly raise the serum calcium. And then finally, just like patients with diabetes, patients who have proteinuria, which is evidence of kidney disease, should be placed on an ACE inhibitor or ARB, because these drugs are renal protective. Now I'm going to talk about what to do in cases where patients present with severely elevated blood pressure. And the first topic we'll talk about is hypertensive urgency. This refers to severe hypertension without evidence of end organ damage, and we'll talk about what end organ damage is in a minute. There's no definite blood pressure value which defines hypertensive urgency, but most people say hypertensive urgency is when the systolic is over 180 or the diastolic is over 120. So in contrast to hypertensive urgency, patients who have hypertensive emergency, also called hypertensive crisis, have severely elevated blood pressure, and they have evidence of end organ damage from that elevated blood pressure. Just like hypertensive urgency, hypertensive emergency has no definite value, but most people agree that it's present when the blood pressure is over 180 systolic or 120 diastolic. And often this occurs in a patient who has long-standing hypertension and suddenly stops their meds. You don't usually see this as an initial presentation of new onset hypertension. The end organ damage that defines hypertensive emergency can include neurologic impairment. This could be retinal hemorrhages or encephalopathy, which would present as confusion. It could include renal impairment, so patients with severely elevated blood pressure can develop acute renal failure, they can develop hematuria or proteinuria. And then finally, it can include cardiac ischemia. When the blood pressure is this high, the afterload is very high, and this can lead to chest pains and symptoms of angina. So any of these things are evidence of end organ damage, and when they're present together with a very high blood pressure, that's called hypertensive emergency or hypertensive crisis. And then a final term you will sometimes hear is malignant hypertension. This is sometimes used to refer to hypertensive emergency where there is papilledema on fundoscopic exam. This is what papilledema looks like here. This is really just a subset of patients with hypertensive emergency. Hypertensive emergency is usually treated in the hospital because it generally requires intravenous medications. And the goal is a gradual reduction in blood pressure. You want to decrease the mean arterial pressure no more than 25 to 30% over the first 2 hours. And the reason for this is because if you drop the blood pressure too fast, that can suddenly drop the blood flow to organs and cause ischemia. And your goal usually is not to get the patient down to a normal blood pressure. The goal is to get them down to a pressure under about 160 over 100. Then they can be sent home from the hospital, and you can work on improving their blood pressure with oral drugs over time. The drugs that can be used for treatment of hypertensive urgency are shown on this slide. They're all intravenous. Hydralazine is a direct vasodilator. Esmolol and labetalol are beta blockers that are short-acting and intravenous. Nitroprusside is a vasodilator that promotes nitric oxide release. I'll talk about how it works in a minute. And clofidipine or nicardipine are calcium channel blockers. So nitroprusside is a very powerful antihypertensive drug, generally only used in the setting of hypertensive urgency or emergency. It's a short-acting intravenous drug, and it causes smooth muscle relaxation. In the venous system and in the arterial side, this will lead to vasodilation. So by causing arterial or vasodilation, this lowers the afterload, and that lowers the blood pressure. By causing venous dilation, blood pools in the venous system, and this lowers the preload, which lowers the cardiac output, and that also lowers the blood pressure. Although it's very powerful at lowering the blood pressure, it does have an important toxicity you need to know, and that's cyanide toxicity. This only occurs with prolonged use. If you look at the top right side of the screen, this is the structure of sodium nitroprusside, and all these groups here are cyanide moieties. So if you administer this drug to a patient for a long period of time, they will develop cyanide toxicity. Cyanide inhibits the electron transport chain, and after being on nitroprusside for a couple of days, you can develop toxic levels of cyanide. This generally never happens in the modern era because we don't allow patients to stay on this drug for more than about 24 hours or so. If patients are left on this drug for long periods of time, the inhibition of the electron transport chain will lead to a life-threatening lactic acidosis. I'll finish this video by mentioning ambulatory blood pressure monitors. This is a picture of a patient wearing an ambulatory blood pressure monitor shown on the screen here. There's a cuff that goes around the arm and it attaches to a unit that can be latched to the belt. And the idea here is that patients will wear these monitors for 24 hours, and every 15 minutes the cuff will inflate and check the blood pressure. And this will allow you to see what the blood pressure is doing on average over the course of the day. And this can be useful in a number of situations. We especially like to use this when the clinic blood pressure may not represent the average blood pressure for any reason. So for example, we've already talked about white coat hypertension. This is when there's elevated blood pressure in clinic only. If you suspect a patient has white coat hypertension, you can have them wear an ambulatory blood pressure monitor, and it will show you that the blood pressure, while it's high in clinic, is normal through the course of the patient's normal activities. There's also a phenomenon called masked hypertension. This is when patients have normal blood pressure in clinic only, but at other times of the day they are hypertensive. So if you suspect masked hypertension, that's also a situation where you can order an ambulatory blood pressure monitor to make the diagnosis. And that concludes our video on hypertension.